इसको फुल स्क्रीन नहीं होता, फुल स्क्रीन डिस्प्ले okay. Okay, my friends, we are going to have today a revision class on epidemiology, basically an introduction to epidemiology, and we will try and cover causation of disease also. So we're going to go through this, try and go through this rapidly. So if you look at the history of epidemiology, most important story which we have is John Snow, where he had this particular area in London where we had the cholera outbreak, and then he did an excellent spot map, made a spot map in which he detected where all the cases were taking place. And then when he found that there was a clustering of cases near the Broad Street pump, and he then informed the people that the Broad Street pump is the one which is causing the problem. They did not listen to him. Then he took off the handle of that pump, and once he removed the handle of the pump, and people were unable to drink water from the Broad Street pump, they found that the number of cases of cholera in that area went down. So proving in an indirect manner that it was actually the Broad Street pump which was creating all the problem of cholera. So John Snow is therefore known as the father of epidemiology. But the definition you will have to remember the definition of epidemiology: study of distribution and determinants. Distribution means how many cases, where are they? Determinants is where, why, how. All these things is determinants of health-related states or events in a specified population. An application of this study to the control of health problems. Please mark this up. So three components which are there of epidemiology: disease frequency, distribution, and determinants. So now disease frequency, we measure this disease frequency, we measure disability, death, and basically this is quantitative in nature, and then we do a biostatistical work on it, and you can measure things like BP, cholesterol, height, weight, and then compare it to disease to the rest of the population or to some other groups. Distribution can be, please remember this, three things in distribution: time, place, person. Time, place, person. Now, time, place, person, your time, you're talking about the year, the season. There are cases which increase with seasons. You have got all the respiratory group increases with season, or you have just after the monsoon you have got malaria, things of the sort. Month, week, the hour, day, it all we can talk about time, place, climatic zone, country, urban population or rural population, the community, the town, the city, the institution, and person. You got lots of things in person. Basically, you talk about a human person. So whether it is age related, whether it is sex related, whether male or female is more, marital status, whether married state or not, occupation or whether it is related to occupation, social status, education, behavior, birth order, family size, height, weight, blood pressure, cholesterol, personal habits, all these things. This aspect of epidemiology is called descriptive epidemiology. And then you look at the determinants of disease. Determinants of disease is when you're testing these hypothesis. And this we test from analytical epidemiology. Okay. You must know the aims of epidemiology. That is, one, to describe the distribution and magnitude of health and disease problem in the population, to identify the etiological or the risk factors, the pathogenesis of the disease, to provide the data essential to the planning, implementation, evaluation of services for prevention and control and treatment of disease. These are the three more important ones. Then also we have other aims of epidemiology. Please read it up from your book. Now, Two types of epidemiology which we have is observational studies and experimental studies. In observational studies, when you're observing, experimental is you're trying to put in something new, or intervention studies, while observational studies is just observing. So observational studies are two types: descriptive, as we had already told you about, and analytical, where you analyze. And analytical, we do either a case control study or a cohort study. We will be talking about it in detail in the next few classes by some other faculty. So when you compare epidemiology and clinical medicine, basically clinical medicine is associated with a case or cases. In epidemiology, we deal with defined population. Clinical medicine person is concerned with individual patient, while here we are concerned with the entire population. In clinical medicine, the physician wants to come to a diagnosis, and so that he can give a treatment to them. Epidemiologist, he basically looks at data to identify particular source of infection and what are the risk factors which are involved, and so that he can determine the future trends and recommend control measures. In clinical medicine, the patient comes to a doctor. In epidemiology, the investigator goes to the community. The subject matter of clinical medicine is easily perceived by such techniques as clinical and laboratory examination. Very easy to this thing you can diagnose. While epidemiology generally is a concept with tables and graphs, etc. Most epidemiological inquiries could never be established without appropriate. But the thing is, clinical and epidemiology is not the clinical and epidemiology separate. They are synergistic. Without clinician, an epidemiologist will not be able to carry forward his studies. And without an epidemiologist, the clinician will never know the clinical course of a disease. And so he will never be able to he will never know how properly to treat a disease. So the epidemiological approach is basically to ask questions and make comparisons. So what are the questions which we ask? The health related events is what, how, where, when, who, and why. 6 questions which you must ask. The means of asking questions and getting answers is basically epidemiology. So what is the event or problem? How much is this magnitude? Where did it happen? When did it happen? Who are affected? And why did it happen? If these things are answered, we know the complete history of the disease. Okay, these are the various other questions which can be asked regarding the health actions. I will not go into details of this, but basically you can read it up. And then you can compare these with various other groups. The first consideration is to ensure that they are comparable. Both the groups must have similar characteristics like age and sex composition. The data should be accurate and gathered in a uniform way. Then what you talk about is matching, randomization, and standardization. Matching means similar. The things should be similar from this group and that group is similar. Randomization means every person will have the chance of getting picked. So, and you pick out a person with the random tables or some other way. We'll teach you that. Standardization, that is, you have basically you should be able to make out in this community. You should be able to compare, and once you have to compare, you have to standardize the things. Basic measurements in epidemiology, when we need a clear-cut and standardized definition. What is to be measured and criteria to be used for measuring and methods of recording it. So we will be measuring mortality, morbidity, disability, natality, or for that matter, the presence or absence of distribution of characteristics of disease, or medical needs, healthcare facilities, presence and distribution of disease, environmental factors, other factors causing it, demographic variables. So you can have a lot of measurements, lots of measurements. And what we normally use, the tools which we use are rates, ratios, and proportions. What are rates? Rates it measures the occurrence of particular event in a population during a given time. How much is the event in which population at a particular time? That's what. Like for example, death rate. Number of deaths in 1 year in mid-year population out of 1,000. That's basic. So deaths 1 year mid-year population. These are the things which I can. But this also can be crude death rates or specific death rates. We can, or you can standardize the death rates. We'll not go into details. Please read up. Ratio is two things are not in rates. One aspect with the numerator and was a part of the denominator, while in ratio the numerator need not be a part of the denominator. So number of children with scabies, but you don't find denominator as total number of people. You find number of children with malnutrition, totally different. So a ratio is when the two things, numerator and denominator, they are totally different, but you want to still compare them. Proportion, again, you will be is in relation to it should be a part of the whole, So you have number of children in scabies with total number of children in the village. So this can be counted as a percentage or whatever it be, this thing which is there, you can count as a proportion. Well, rates are per 1,000, per million, or whatever. Well, we will not really go into details of this concept of numerator and denominator. Please remember that you've got a variate and a circumstance which takes place. So the numerator and denominator are very important when you're calculating rates, ratios, or proportions. So what are the things which you normally take on? Mid-year population, population at risk, or a person time, or a person distance values, or subgroups of the population. Okay. Now let us jump into causation in epidemiology. What's a cause? Cause is capable of conveying the notion of a significant effectual relationship between the agent and associated disorder or disease in the host. Basically, what you're looking at is something which causes significant and causes a relation effect in a particular individual because of a particular agent. So that is what is cause. Now, when we talk about association, the association can be a clinical association or it can be a statistical. The statistical, when you talk about, you have to look at the causal significance of an association. This is a matter of judgment. Okay, we will not go into details of this. Basically, let me try and explain to you. You see, if a person has got hypertension, the chance of his child having hypertension is there. So there is a genetic background. Is that the cause of the disease? Now, there may be an association, but is it the only cause? One has to consider that. So there's a difference between association and causation. When you want to find out whether the association is resulting in the causation, the following conditions have to be met. That is, the study sample has adequate sample size, free of bias, and the thing is, the confounding variables should not be there. Like for example, if you're trying to look for cervical cancer in males, you will not get cervical cancer because there's a confounding in that which says that males cannot have cervical cancer. So you must remove what is confounding, what can confound the results. To say that there's a huge difference between cervical cancer between males and females is wrong, because it cannot occur in males because they don't have a cervix. There's an exposure between exposure of interest and disease outcome. So we have to find out whether the association is causal or not. So to know that, we go back to Henley Cox postulates, who said the organism must be found in all animals suffering from the disease but not in healthy animals. The organism must be isolated from the disease grown in pure culture. And the cultured organism should cause disease if introduced into healthy animal. And the organism must be re-isolated from this infected animal. So generally what we do is we do a clinical observation that we think that there is an association, and for that we look at data, which we do a cross-sectional study, and then we see that the data is showing some relationship, then we go into a case control study. And if you want to really do something, then if you really want to confirm it, best is to go in for a cohort study, very costly, but you can go in for a cohort, observe a group of individuals, and then you can also carry out randomized trials, that's for various treatments, etc. So now let's give you an example. One surgeon, Otto Oshner, observed that all lung cancer patients were smokers. The ecological study of per capita smoking and lung cancer incidence was done, and then after that they did a case control study of lung cancer patients versus those without lung cancer. So various steps which were followed. So when you say that something is associated or causing a disease, whenever there is an association, there can be two things: either it is the cause of the disease, or there is no cause. So two types of association can be there. Even a causal relationship can be direct or indirect. Now, for example, diabetes is caused only by genetic? No, it is caused by genetic, but we have got some other factors like lifestyle, which creates the conducive conditions for it to occur. So this can be a direct or an indirect relationship, and it could be sufficient or necessary when the causal factor which is there. So real association is present if the probability of occurrence of an event or quantity of a variable depends upon the occurrence of one or more other events, characteristics of or variables. So that's a real association. The spurious association, there can be biases or there can be confoundings. So that's resulting in a spurious association. Let's see one example which is there. We have, this causal association, you have one particular factor causing the disease. In this, you have a characteristic under study, but the disease is reformed because of some factor which is there, which can confound the results. So let's see this particular example which is there. Coffee consumption and pancreatic cancer. In 1981, McMahon reported that in a case control study, that study of cancers of the pancreas, there was an apparent dose response relationship because people who took coffee were developing cancer of the pancreas, and this was more in women. So was the disease caused by coffee consumption or some other factor? What was happening was whenever people had coffee, they used to also smoke. So though smoking was the cause, as we know now, but at that time it was said coffee consumption could be the reason for the relationship. So smoking was the reason, closely associated with with many studies which were done, then they subsequently were able to produce the results. So basically there is mentioned real association, or is it coffee consumption with smoking and then you get cancer. Okay, there can be multiple factors involved. We'll not go into detail. So if there is a real association, you believe it to be causal, figure out that it is a direct causal relationship and sort out the necessary versus sufficient factor. Now, have you proven causality? No, you have to go through various criteria. 9 criteria have been defined by goddess, and we should know all these 9. There should be a temporal relationship, strength of association, biological plausibility, dose response relationship, replication of findings, effect of removing the exposure, effect extent to which alternate explanations have been considered, specificity of the association, and consistency with other knowledge. So you must please remember all these 9 criteria. So first, the temporal relationship. If the disease is occurring before the particular causal factor comes into play, then where is the question of there being that causing the disease? You're having it before, or the action already started before, then there is no relationship in time. So exposure precedes the disease development with adequate elapsed time. Then this latency period, time for initial exposure of an agent to the onset of the disease. It may be that exposure has taken place for a long period of time, like in silicosis, for months or years the exposure has taken place. And then the disease comes. So we have to look for all these factors. You cannot define that it will be 6 months, 2 months, or something like that. It can be a year. It depends on situation. Uh, in infectious agents, you'll have to show exposure to the infectious agents or the incubation period, and there'll be study designs with temporal ratio, cohort, case control, or even an RCT. So basically, this is what I was talking about. Asbestos latent period of 10 to 20 years is there. So but now we are seeing that even after 3 years we get cases of lung cancer. So then we go into strength of the association, where you have to see the measures of how strong is the association. This we decide with a relative risk or an odds ratio. We will talk about these in detail whenever we talk about it. So, like for example, there's a very strong relation between cancer and cigarettes. Then the larger the relative risk or odds ratio, the higher the likelihood, and must examine the confidence interval and the sample size also before deciding on it. So, not go into details. Biological plausibility. Is it biologically plausible? You say that, for example, people who walk on the left side of the road will produce only males. Is it biologically plausible? Are we talking nonsense? So biological plausibility should be there. So cigarette smoking releases some carcinogens, and these carcinogens go on to DNA adducts, and then the mutation which takes place, and that results in lung cancer. Next is the dose response relationship. If you increase the dose, does the disease occur more? That's to check, not necessarily in all diseases. In some diseases, you will find that if you increase the dose, the response is more. Okay. Can you replicate the findings? If the same study is done in place B, will the population also produce the same result? That's very, very important point. If you remove the exposure, then the disease decreases. This is what you should try to do. Maybe, but sometimes when permanent damage has been done, you cannot possibly change it. But otherwise, you remove the exposure and you will find that the disease goes on decreasing. The graph shows removing exposure, benefits of quitting smoking. Okay. Extent to which alternate explanations have been considered in the study. You have look for alternate explanations. Can coffee consumption lead to pancreatic cancer? If not, then what are the other more plausible explanations? So this is what we have to go into details. Now, also whether this reaction is specific or not. Does smoking cause only lung cancer? Very important to discuss and decide on it. So one has to see this particular. The weakest of the criteria is this particular one, and this is caused with tobacco companies who argue that smoking is not causal for causal for lung cancer. Smoking is associated with many diseases, so not only with lung cancer. Also, consistency with our current knowledge, which is there. You can do in vitro studies, you can do animal studies and test what you are trying to prove. If lung cancer incidence increased as cigarette use was on the decline, we would have been able to explain how this was consistent with casual causal behavior. It should be possible. So that's all that I have to say to you. Please read up and keep revising your subject. You will possibly, I am told that there's a likelihood that you all will be coming by December end or December middle or December end, and then we should be having your final your internal assessment as well as your final exam in the month of January, February. So please read up, keep yourself abreast, and ensure that you do well in your exams. Thank you.